Hi, I'm Dr. Scott Talbert with the American Institute of Personal Injury Physicians, and today we have a very special guest and expert interview, Dr. Daniel Lieberman, a neurosurgeon from Phoenix, Arizona. We're going to ask Dr. Lieberman a few questions about the cervical spine and spinal cord and some of the injuries that we see as physicians and how to better manage and handle those. So Doc, you had mentioned in a previous webinar that radiculopathy has to have three components. Does it always have to have those three components of sensory, motor, and reflex loss?
It's a good question. Radiculopathy is a disorder of a nerve root, and the nerve roots basically have three functions: motor function, sensory function, and reflex function. When we examine somebody clinically, even if they have a little bit of impairment, it may be below what we can detect. So sometimes there's so much sensory loss and a little bit of motor loss and a little bit of reflex loss that we'll say, yeah, that's enough information to conclude that they have a radiculopathy. So whereas technically they should have all three, in clinical practice you have to make your best estimate based on what you find on examination.
Okay, great, thank you. And how about if they just have one, like sensory or motor? You had mentioned that motor is significant, so can you expand on that? Because sometimes as clinicians we find that weak deltoid or that weak bicep. Clinically, can you just expand on that and how significant that is?
The radiculopathy usually results from compression of the nerve root, and the different fibers in the root are going to be differentially sensitive to compression. So at a really small compression, you'll probably pick up some sensory loss. As the compression gets worse, you'll get into motor loss, and then as it really gets severe, and over time, you'll see the reflex changes. As a result, if you just have a little bit of motor loss and a lot of sensory loss, and the patient's not in a lot of pain, that's probably a mild radiculopathy. As you start seeing more and more motor issues, you need to be more and more concerned that the nerve root is compressed in a way that is going to be functionally limiting. And those are patients who you really want to think about other interventions for earlier rather than later.
Great. And how about the disc bulge on an MRI? Is it always based on size, or is it a combination of the size as well as the patient's symptoms? Can you expand on that a little bit?
There seems to be a really wide variety of responses to the same disc herniation. So if you had a 4mm disc herniation evident on MRI, a lot of people are walking around hardly even aware of it. Whereas another person is going to have a true radiculopathy with that same disc. What makes one so symptomatic and the other not is likely related to the inflammatory component of the disc. But in any event, looking at it from the outside and from a clinical point of view, it's really hard to predict just based on the MRI what the implications are going to be. So you really have to look at both. Now, if your MRI is showing a disc herniation that's bigger than 5-6 millimeters, that's something that's getting large enough that manipulation of the neck or movement of the neck has the potential of causing significant injury. So at that point, regardless of their clinical, I would start getting concerned about that patient. For most patients, though, who have disc herniations much smaller than that, I would base it on their clinical response on your examination. Did they have a Sperling sign? Did they have motor, sensory, and reflex changes? And if the answer is no, and the disc is 4 millimeters, they're probably perfectly safe to undergo other treatments.
Okay, great, thank you. Can you just describe the difference between radiculopathy and radiculitis from a clinical point of view?
Great question, because it comes up all the time. Radiculitis is an inflammatory disorder of a nerve root. So the disc is touching up against the nerve root, it's irritating it, you get some sensation of tingling in the arm, maybe you feel weak but you're not really weak. Radiculitis is an inflammatory disorder of a nerve root. Radiculopathy is a functional disorder of a nerve root. So radiculopathy is where there's actual altered transmission of impulses by the nerve root down into the arm. And radiculopathy is going to be confirmed on an EMG. So the two conditions kind of present a lot the same. They mimic one another. There are different effects on the same structure, namely the nerve root. Radiculitis is very safe to undergo a variety of treatments and is really going to respond to treatments. Radiculitis is almost always self-limited. 9 out of 10 cases are going to resolve on their own over time. It's an inflammatory condition, responds to medications, responds to manipulation. Very, very treatable. Radiculopathy is a different animal. Radiculopathy is a nerve root that has sustained a functional injury, is more likely to sustain additional injury with manipulation, and is also more likely not to get better on its own without some kind of intervention. So it's very, very important to distinguish the two, and the way you distinguish them starts out with the examination and then goes into an electrical test like an EMG.